Good afternoon, everybody. I'm Ashraf Kaji, the co-director of the Alan J. Fleischer Center for Public Mental Health. My co-director is Professor Catherine Sorsdahl, who is also with us today. And I'm very pleased to welcome you all to this annual lecture of the center. This is the Alan J. Fleischer Memorial Lecture in memory of our colleague and founder of the center, Alan Fleischer. We want to especially welcome Alan's family, Meronisa, Adam, Kalila, Alan's mother, Jean, and his sister, Alison. They are not with us at the moment, but they will be viewing the video later on. We do this lecture under very difficult conditions, under conditions of living under the COVID pandemic. And at this time, the issues of public health and public mental health are extremely relevant and important. So it is my great honor to introduce our speaker, Professor Inge Petersen. Inge is research professor in the College of Health Sciences at the University of KwaZulu-Natal and director of the Center for Rural Health in the School of Nursing and Public Health. Inge has extensive experience in working towards integrated primary mental health care in low and middle income countries. She has participated in a number of research consortiums and studies in Africa and Asia over the last 15 years. Inge is currently the overall hub lead for the Southern African Research Consortium for Mental Health Integration, funded by the National Institute of Mental Health. Professor Petersen, over to you.
Thank you very much, Professor Kaji and Professor Sorsdahl, for inviting me to give the Alan Fleischer Memorial Lecture this year. It is a huge honor, and I was very privileged to have worked with Alan in the Mental Health and Poverty Project over a decade ago. This was one of the first global mental health projects. It was funded by DFID and led out of UCT in the Global South. And this is testament to Alan's academic excellence and visionary leadership. Alan's vision for public mental health provided much of the inspiration for the work that I'm going to be sharing with you today. And I do hope that this work does justice to his vision and his spirit. So I'm going to start with the presentation. So what I'm going to be sharing with you is some of the lessons of the research group that I've been working with over the last decade, really, which has culminated in the Mental Health Integration Project and the Southern African Mental Health Integration Project, which is SMhINT, which is the NIH hub. So just a brief history then, that this work really started with the program for improving mental health care back in 2012. At that point in time, I was a South African PI, and we worked in the Dr. Kenneth Kaunda district in the Northwest. I'm sure many of you are familiar with PRIME. It was led by Professor Prof, who was previous director for the center, and it was looking at implementation and scale up of integrated mental health care at district level across 5 different countries. We engaged in a number of research studies. We were asked in South Africa to look particularly at how we could integrate mental health into an integrated chronic disease platform that they were piloting in the Northwest Province at the time. We co-developed a collaborative care model for this, which focused on depression and alcohol misuse in particular, and we then evaluated it through both using a quasi experimental design initially, followed by 2 cluster randomized controlled trials. The one was PRIME, which focused on depression in hypertensive patients, and the other was COBALT, which was co-led by Professor Lara Farrell from the Knowledge Translation Unit at UCT, Professor Graham Thornycroft from King's, and myself. And that trial looked at depression in HIV patients on ART. Following this, we have received funding from the CDC to look at how to scale up this package. And this work this funding was really obtained through much of the work of Professor Deepa Rao at the University of Washington. And we have worked with the University of Washington since in obtaining money as well for the Southern African Mental Health Integration Program, which is evaluating this SMhINT package in South Africa using implementation science, and we also collaborate with both Tanzania as well as Mozambique on this. So with that background then, what I'm going to focus on is the latter part of this history, but I wanted to just foreground what I'm going to be talking about to give you some idea of where this work comes from. And in terms of the outline for this presentation, I'm going to be focusing on the why and the what questions relating to integrating mental health to primary health care. I'm going to go then into more detail on how to do it in the real world, because I think that this is an issue that the global mental health community is grappling with at the moment. And then finally end up with some lessons learned from our experiences for the global mental health community. So in relation to the why and the what, first of all, besides primary healthcare providing a platform that potentially increases access to mental health care when we integrate mental health into primary healthcare, it's really important from the perspective of the fact that we have a rising burden of multi-morbid chronic conditions. And in many low and middle income countries, and certainly in South Africa, the majority of people with these chronic conditions access care from the primary healthcare platform. And we know that there's a bi-directional relationship between mental health and people with physical conditions, particularly chronic conditions. We know that people with chronic conditions are more vulnerable to mental health conditions, and having a mental health condition can also make you more vulnerable to a chronic condition. And we also know that mental physical multimorbidities lead to poorer adherence to treatment and poorer health outcomes, as well as an increased burden on the healthcare system. So then what to do to integrate? So we also know what to do to integrate. There's a large body of accumulated evidence now on the effectiveness of task sharing, of mental health treatments with general healthcare providers, and much of this evidence comes from low and middle income countries. We also have evidence of the effectiveness of collaborative care within primary healthcare on improving physical health outcomes, and this is mainly though from high income settings. So the big question now is, how do we do this in real world settings? So how do we integrate mental health into primary health care, into routine primary health care? And I'm going to share with you a bit of the experiences from the MINT and SMhINT work that we've been engaging with over the last 3 to 4 years. In summary, there are 3 main streams of work that we've engaged with. The one is technical support, which is provided by MINT, the CDC-funded component of the project. We have engaged also in another stream of work, which is implementation science research, which is funded through the SMhINT NIH-funded project. And then we've also engaged in system strengthening work to create an enabling environment for integrated mental health care within the primary health care platform. So moving on to the technical support component, the original MINT technical support package was really based on the PRIME program. And here we focused mainly on improving the supply of services. And we did this through really leveraging existing services within the healthcare system, and starting with adult primary care. And this adult primary care is an integrated set of chronic care guidelines which was developed by Lara Farrell and her team at the Knowledge Translation Unit and adopted by the National Department of Health and scaled up countrywide. What we have been working on, and this really is the work of the Knowledge Translation Unit, is to strengthen the mental health module for these guidelines. And then we have also linked to that, strengthened the referral pathways, and in the absence of mental health specialists, we have worked to develop a co-located counselling service within the primary healthcare facilities and focusing on depression as well, using CBT and problem solving techniques. In terms, and then, obviously people with more severe, moderate severe and severe depressive symptoms would be referred up the referral pathway either to primary healthcare doctors to initiate antidepressant medication, because in South Africa nurses are not yet able to initiate such medication, and then to district hospitals where the majority of our specialists are located. Just to give you an example, in the district that we're working now in Amajuba in KwaZulu-Natal, is roughly about 500,000 people, and the available specialist resources are 2 psychologists and a sessional psychiatrist. So in terms of implementation strategies, we've used guidelines, obviously cascaded model of training. So we've leveraged the existing model of training in South Africa, which uses this cascade model where you have a master trainer who trains through the regional training centers, trains district trainers who then train facility trainers, primary healthcare facility trainers, who then train the providers. We've also included quality improvement mentoring, which is a crucial element to embed these various innovations into the system and to work with the managers and providers to identify bottlenecks and solutions to those bottlenecks. And then supervision is another very important component in terms of implementation strategy. And this is especially, as we know, especially important for the lay counselling services. Just to say, with those counselling services, we have used existing people within the system. So these include both existing HIV counsellors as well as enrolled nurses. And in KwaZulu-Natal, the HIV counsellors who are not on the wage, they're not paid directly through government, are being phased out. And so we've started to shift to training enrolled nurses who are within the system. So I'm going to now move on to the evaluation component using implementation science. So what have we been doing to evaluate this initial model? And the idea behind using implementation science to do this is really to see how this initial package needs to be strengthened in order to enable implementation and scale up in the real world. And we have we're using a mixed method observational implementation research design. So this design is iterative and it's embedded within a learning health systems approach, where there are 2 main stages. So in the brown here is really the SMhINT intervention, and the green is really the SMhINT evaluation. And we are using re-aim outcomes. So we are evaluating the outcomes of the model using the re-aim framework, which stands for reach, effectiveness, adoption, implementation, and maintenance. And then understanding these re-aim outcomes using the SciFi model or framework, rather, which really looks at multi-level determinants of the outcomes that we see on the re-aim framework. The idea is that as a result of this, we would engage in strengthening of the initial SMhINT model, and then we would evaluate it again. This time, the first stage is in an urban subdistrict, and the second stage would be across 3 different contexts, so urban, peri-urban, and rural. And we would engage in the same design with the idea to strengthening it further for full scale up. So in terms of the methods, we are adopting multiple methods. I'm not going to go into too much detail on those, but people can, this protocol should be published quite soon in psychiatric services. Highlights from stage 1. So we are still in the process of engaging with this work. This work is likely to actually carry on for many, many years because it's iterative and we're learning all the time how to adapt and ensure that the model can actually be embedded and scaled up in the system. So these are just highlights. First of all, in terms of reach, so we have engaged in a study led by Chris Kemp, which was one of our Washington colleagues, looking at the cascade of care from diagnosis, referral to uptake from the first stage. And what we found here, we used the baseline data from our cohort study to do this. And what we found that nurses, we screened people using the PHQ-9 in the waiting rooms. What we found was of those patients, and this was across 10 facilities who screened positive, 49% were diagnosed. Of those who were diagnosed, 37% were referred, which equated to 18% of the initial sample. Of those who were referred, 25% then took up the referral that they were given, which equates only to 5% uptake. So you can see this sort of gradual dilution, in terms of or reduction in reach along the cascade. What we also found was that nurses were more likely to refer patients with more severe depressive symptoms. They were also more likely to refer patients with severe depression symptoms. But when we looked at uptake, we didn't see the same pattern. So patients with severe depressive symptoms were not more likely to take up the treatment. And this is available in this study has been published for people to review if they wish. So in terms of probability of detection, there were this probability increased if there was an increase in depressive severity, if there was also an increase in perceived stress, as well as an increase in reported alcohol use. In terms of the probability of referral, the probability of referral actually went down in the presence of when there was an increase in chronic disease, which is a bit concerning given what I previewed, the importance of actually treating common mental disorders in people with chronic diseases. And then the probability of uptake, when this went up when there was a decrease in social support as well, which I think is understandable as well. So then briefly in terms of effectiveness, what did we find in this first stage? What we found from the cohort study is that patients who were, we had 3 different cohorts then, those who were diagnosed and referred, which is the brown bar, were twice more likely to have a 50% reduction in PHQ-9 scores. And this went down slightly at 9 months follow-up. So there was some level of stability of effects. In relation to adoption, here what I'm going to report on is some interviews that we've had with nurses on factors promoting adoption, because nurse identification or diagnosis and referral seems to be a bottleneck within the system. We are still currently engaged in interviews with managers and other providers as well as patients. We were starting those or continuing with those in March when we had to stop field work, unfortunately. But we do have the results from the interviews with the nurses, and we divided them into high and low referring nurses because we found that was a pattern, as we had also found in prime. So in terms of the SAFI framework, which is multi-level, at an individual level, the nurses reported that increased training exposure did help with making a diagnosis and referral. In terms of the inner setting, which really refers to the facility as well as the healthcare system, the barriers that were reported was the cascade model of training, which tended to dilute both the training as well as the coverage of the training. Poor psychosocial support was came up a lot, and this was in the face of nurses' own emotional issues not being attended to, which made it difficult for them to attend to emotional issues in their patients. High workloads, obviously, and then not having a validated screening tool emerged as an issue. So although there was an indicator for screening and there was screening occurring in the facilities, there was no validated screening tool, so they couldn't rely on the patients where the enrolled ENAs had indicated there was a positive screen. In terms of the outer setting, and this really refers to community level factors as well as the broader policy environment, low levels of mental health literacy emerged as an issue. They said it was quite difficult to actually diagnose depression in patients who had low levels of mental health literacy, as they were less forthcoming with their symptoms. And so, I mean, that also fits with them diagnosing patients with severe, very obvious symptoms. And then in terms of intervention characteristics, one of the barriers that emerged here was the additional time that this takes. So integrating mental health care does take more time, and there's a price tag attached to it. And we really need to pay attention to that in terms of the broader policy environment. Just looking at implementation, I'm just going to briefly touch on one slide just to substantiate some of the findings from the SAFA interviews. There are many others here. I'm using the District Health Information System data just to show you that there was no consistency in screening, and the screening that was done was very unreliable. So some facilities actually showing over 100% screening rate. So the quality of the data could not be relied on, which is obviously, you know, an issue. And during the CQI processes, the continuous quality improvement processes, that not having a validated screening tool or, you know, a standardized screening tool across the facilities was identified as the problem of this. So what have we done so far then in terms of strengthening the mental health integration intervention? So efforts to date to strengthen the MhINT intervention package. And what I'm going to be doing here is actually taking you along the cascade of care and looking at what we've done at each point along the cascade to strengthen the MhINT program. So starting off then with the community, at the community level. So previously, the MhINT program didn't have a community level intervention. And so in relation to responding to the need to improve mental health literacy, but also in response to a request by the Department of Health for assistance with regard to developing a screening tool for the community health worker training program that they were wanting to roll out for our ward-based outreach teams, we have developed a community mental health education and detection tool. This tool, and there's a picture of one page from the tool, is really based on the community identification detection tool developed by Mark Jordan's, Professor Jordan's, in the PRIME project in Nepal, and we have really adapted it for our context. So the idea is that this tool both provides psychoeducation as well as a tool to help community health workers to screen or to identify potential cases. A story is read to to the family members. Family members are asked if they can identify with if there's anyone in the family who has similar symptoms, and then they are also asked whether the problem, there's a little algorithm on the side, if the problem impacts negatively on their daily activities, and then if yes, they are asked whether they would like a referral. So we're really wanting patients to understand why they might be getting a referral. I'm sorry, not patients, these are community members, why they're getting a referral rather than just being told, you know, you have depressive symptoms, please go to the clinic. Then moving on to the second element along the cascade of care. So when people come to the facilities, what we've done here, and this is also in response to the COVID-19 pandemic, where we have been supporting the provincial KwaZulu-Natal Department of Health to strengthen the psychosocial response. And in the context of increased demand for mental health services, and as well against the backdrop of limited specialist resources, as well as, you know, just it being the whole issue of social distancing, we've tried to strengthen the psychoeducational material. And here what we've done is we've developed a series of morning talks, but also posters using a stepped up approach to psychoeducation, where patients are initially given some tips on how to cope better. Then we've developed a series of online self-help videos which draw on CBT techniques for both anxiety and depression, as well as for grief and bereavement, and these are available on the CRH COVID-19 hub, and they're data free. They're also available as YouTube links for the public. And just to say that this strengthened psychoeducational package has been rolled out across the province of KZN. We have trained mental health coordinators using the cascade model in this package with the view to them rolling it out in their respective districts. And thank you very much to Jill Farris, whose creativity has resulted in this amazing suite of materials. And moving on to the next stage of the cascade, which is, so then the patient comes in, they get exposed to a morning talk. At the moment, we're looking at where best that happens. Outside, where COVID screening takes place, is where it probably will happen, where other health talks happen. In terms of the screening for so one of the big issues that I touched on was the fact that there was no validated screening tool. So in response to this, we've been working in collaboration with the Department of Health to validate a screening tool. So we now have a validated brief mental health screening tool. We then worked with the Department of Health to look at how best the screening tool should be administered within the routine primary healthcare setting. This resulted in a standard operating procedure for how it should be used, as well as a training manual. And using the same cascade model of training, this screening tool has now been cascaded across the KwaZulu-Natal province, where all the district mental health coordinators have been trained to train in their respective districts in the use of this tool. So this has been, as you can see, it's been adopted into policy. Moving on to the next element of the cascade. So after the patient's screened in the vital signs room generally, then they go and see the professional nurse. If they screen positive, then it alerts the nurse that they should do an assessment. We have also strengthened the APC mental health module training through, in this last period of funding from MINT, for this to now be available online. And this is the work of the Knowledge Translation Unit. And thank you particularly to Christy Joy Russ as well as Lauren Anderson, have been leading this work. And I believe that all the adult primary care chronic care guidelines and the training that goes with that is now available online, as well as now the mental health module. And this really, we hope, will actually allow nurses to get direct access to the training module. So, to actually address some of the dilution effect of the cascade model of training. What we've also done, and because of COVID, what's emerged, COVID-19, what's emerged, and we know that our healthcare workers have been particularly challenged. We have high rates of absenteeism and burnout, and the need to support our healthcare workers is a global issue. And what we've done here is develop 2 online videos here as well. One for managers to help them to provide containing leadership, because one of the issues that's emerged is really for our providers feeling that they are not supported and contained, and secondly for frontline workers themselves. And here we use problem management skills as again here to help them to cope. So it's really a skills building video as opposed to just tips for coping. So that pretty much is where we're at in terms of strengthening the MINT model in response to some of the problems that have emerged from the research, as well as the continuous quality improvement processes. Our next step is to obviously look at how do we actually improve treatment uptake and quality improvement as well. We then we will be then going into the second stage of evaluation, and this we hope will be towards the end of next year. So the idea is we'll have this completely strengthened package with most of the elements we hope embedded into policy as well, and we will then reevaluate using the same methodology. Moving on to the last stream of work then, which is the system strengthening stream of work. This is really important for creating an enabling policy environment. And here we've adopted a learning health systems approach. And just I have really alluded to this, but using information generated from both the research and the CQI process, so using data, we've developed a provincial learning collaboration with the Provincial Department of Health, where information is fed into this learning collaboration. And together with the Department of Health, the idea is that we co-develop innovations and implementation strategies to respond to the bottlenecks. And an example of this is the brief mental health screening tool. This then gets adopted. The idea is that these innovations, they get adopted into policy. They would then be they're cascaded down to all the districts through the train-the-trainer model, this cascade model of training. And then lastly, what's really important is to have CQI mentorship in all the districts in order to be able to embed and improve performance in the use of these innovations. And here we're also hoping to use the capacity building arm of the SMhINT program. So all the hubs, the NIH hubs, have a capacity building program to do this. So in terms of the M, the maintenance, okay, this is of the re-aim framework. This really happens in the system strengthening component, where you're looking at institutionalization of the intervention. And you can see here how we've adopted a whole system approach where we've trying to embed mental health into the architecture of the health system at all levels. So what are some of the lessons learned then? This is nearly done. I know that people sort of staring into the screen might start to zone off by now, but I'm nearly done. So lesson 1, requires our lessons anyway, requires a multifaceted approach of both technical support, implementation research to assess outcomes and determinants, so we can strengthen the technical support and the innovations, and system strengthening to create an enabling environment. Second, Secondly, we need to adopt a learning health system approach where we really collaborate with providers, policymakers, and ideally consumers in learning collaborations to co-develop interventions. And thirdly, that ideally, if possible, mental health we should try and integrate mental health from the inside out and not the outside in. And so it's much easier if mental health is part of initial shifts towards from vertical to horizontal programming, so that it's not seen as an add-on. So an example of that is the community mental health education detection tool, where the Department of Health is initiating the training program for community health workers, and mental health becomes part of that training from the get-go. And then finally, the last lesson is that this work is a bit like riding an ostrich. I have never ridden an ostrich, but I mean, I've read about it and I can see that it must be very challenging, because there's nothing to hold on to when you're riding an ostrich and you don't really know what direction the ostrich is going in. So we have no clear roadmap with this work. We have to be responsive to policy window opportunities. So, for example, the policy window opportunity to embed the mental health education detection tool within the community health worker training program, and to be flexible. We have to be flexible. So, and we've developed a lot of material that has both responded to the COVID-19 pandemic and the needs of the COVID-19 pandemic, as well as allowing us to address some of the bottlenecks and the problems that we saw through the research. And this does require long-term flexible funding. So we need to be flexible as people doing this work, but funders also need to be flexible, so we can respond to priorities. We can use policy when we can respond to policy windows, and sometimes we have to respond very quickly, and ostriches move very fast. So thank you so much for inviting me to provide this talk. I'd like to really thank Dr. Hongo and her team in the KZN Provincial Health Department, as well as staff and patients. I'd particularly like to acknowledge Professor Arvind Bana from the Center for Rural Health, as well as the MRC, who's been on this journey with me from, for about 2 decades, actually. And Professor Lara Farrell from the Knowledge Translation Unit at the University of Cape Town. We've worked collaboratively on all these projects from 2012, as well as Professor Deepa Rao from the University of Washington, who joined us later, and her wonderful team who have really helped us with the implementation science aspects of this work. And it's been a huge learning opportunity for us at the CRH, as well as, I'm sure, people within the Department of Health. So thank you.
Thank you so much, Inge. We really appreciate you coming all this way and giving our lecture. We've got a number of questions online, and I just also want to mention, when I think of who did implementation science first in South Africa, it's you. You've had lots of experience, so you're almost the first one to ride that ostrich. So it's wonderful for you to give us some tips. So the first one is about, can you tell us a bit more about what co-located means in terms of counseling?
Okay, so I mean that really means that we have so the person isn't referred out of the facility, upwards or somewhere else or sideways, but they're able to actually access the counseling in the primary healthcare facility where they receive their other services. And this is really important in South Africa, and I'm sure in other low and middle income country contexts, because people really don't have money for transport. That's the one thing. And also, because it's not a familiar service, it's really important to try and hook the person who is being referred, and to provide. So the initial session actually provides psychoeducation, and that's really important to hook people to come back further for the counselling. And if that person can receive that first session on the same day that they referred, I mean, we've seen that that really helps for uptake.
So there's lots of questions, there's a few more. So the MINT intervention, how much of it was part of the MHGAP intervention guide? Is it based on that?
So the APC guidelines draw on the MHGAP guidelines.
Yeah, so it's all kind of put together. Wonderful. Can you explain how the cascade model was a barrier to adoption in the inner setting?
Okay,
You
so
touched on it a little bit.
yeah, I did. So that's actually part of the way that the adult primary care guidelines have been cascaded across the country. So the idea that there's a master trainer, so that's generally been a master trainer from the knowledge translation unit, and Professor Laura Farrell I know she's online and she can help answer this. But then that master trainer trains trainers within districts. So each district in South Africa has a district trainer. And their role is to then cascade training within the district. And then each facility, primary healthcare facility, has a facility trainer. And that person is trained by their district trainer to then train people within their facility. So it's, in a way, I suppose that you can see why it can get diluted, because it could be a bit like a broken telephone.
Yeah, sort of barrier at every level. Absolutely. Wonderful. Can you tell us a bit about how the screening tool was validated? Was there a gold standard, and is this work published?
Yes, so Professor Arvind Bana led that. It is published. There is a reference to that.
We'll add it to the
So yeah, I mean, people can actually have a look at that.
Wonderful.
And we used APC, we used that because that was the next level. Yeah.
Can you tell us a bit more of how the data was collected? I know you did also touch on it after I think the question was asked, but how were clients diagnosed, or how many were diagnosed and how many were referred? So how was that data collected at the facility?
Okay, okay.
Yeah, and did they present again later? Did they do an exit study?
Oh, right. So I didn't really go into the details of that study. So we used the baseline data from the cohort study. So patients in the waiting room were screened using PHQ-9. And then we interviewed them after the consultation using an exit interview. So that's how we did it. Yeah.
A lot of resources went into that type of data collection as well. Wonderful. Well, I think that's it for our questions, unless there's more on the online, Claire? Or any from the room? There's a few of us in the room at the moment. So.
And may I just also say, I really appreciate having a bit of the old with the new. So thank you so much for providing a little bit of an audience, seeing that I'm getting quite old now.
Sorry, can you speak loudly?
Yes, of course. So I'll come a bit closer as well. So the time and resource for mental health interventions, do we need to place more emphasis on the time and resource allocation at the managerial level?
At the managerial level?
Yeah, is that the question is correct? Yeah. I guess in terms of the facility managers.
So I think that, we are moving towards integration. I mean, I think we might be able to see how much it might cost. I think that in terms of CQI, if they're going to be engaging in the CQI process, definitely. So I would say, yeah, we probably do need to cost that, factor that in.
Great. Any other questions from the room?
Can I ask something? Buy-in from the provincial heads of Department of Health, how has that been, and how has that helped cascade, to use the same term, or has it been very much buy-in at a local clinic or district level?
So you need both. So one needs both, really. So I mean, I think so Amajuba has been our testing site, if I can put it that way. But I mean, you need obviously the buy-in and at the level of the district. So, and I mean, Amajuba district management are absolutely amazing. And then obviously we need to create the enabling policy environment for district. We really need to engage in this sort of collaborative work with the provincial Department of Health, provincial departments of health, so they can create the necessary policy changes to create that enabling environment. So, for example, the VMH, CMhINT, etc.
And what's your experience been of how they have been engaging with you at the provincial head level?
So we have regular meetings with them. We've got terms of reference now for working, and we have an excellent working relationship now with them. I mean, it can't work otherwise. And I really thank again Dr. Hongo and her amazing team. Without them, this work is not possible. But that requires time to develop, obviously, because it requires trust.
You mentioned at the very beginning about nurses being unable to prescribe yet. Is there a move towards this? Can you tell us a bit more? Yeah.
Yes. So Professor Lara Farrell is working on it. That's what I can say. I mean, I think that it's really important that nurses are able to initiate at least antidepressant treatment, because primary healthcare doctors are not always available. And they're also incredibly busy with dealing with all the physical conditions. So I can say that in the strengthenment package, we'd actually like to see that, but that does require working at a very high level.
Yeah. Right. So maybe over time we'll see movements in that.
And maybe, I mean, I'm sure, I don't know if there's a possibility for people to engage.
Yeah, there's a chat. I'm sure that Lara will be able to answer. Do you have any data on how well the counsellors are coping, those who are providing the mental health interventions?
So we are currently doing interviews with them. We were unable to actually complete those interviews because of lockdown. But what we have continued to provide online support to them, because what normally happens in terms of supervision, that there is group supervision. And so the counsellors actually develop a community of practice where they share, and then there's also the opportunity for emotional support, which is incredibly important. And so they haven't had that over this last period, which is very concerning. And that's one of the things we actually want to work on. So that aspect, we've kind of stopped along the cascade of care. We haven't actually got to that, to strengthening that. But that's one of the things we're talking about, is how do we actually look at trying to provide online supervision in a way that is also is able to actually provide some of that emotional support and containment, which I think is a huge challenge. We're not sure how we're going to manage to do that. And so one of the things is to look internationally as well to see how other people have actually used the digital technology to help provide that.
That's great. Ashraf, any last questions? Wonderful. So firstly, I just want to thank you, Inge, again for coming. Thank you to Machi Marks, who is the wonderful tech person who manages all of these important things here. And thank you to everyone who came today. We will put the presentation is online, and this will be done. We'll be able to send you a link to this presentation if you missed any pieces of it. So yes, thanks again, and we'll hopefully see you next year, hopefully in person, for the Alan J. Fisher Memorial Lecture.
Thank you so much.
Thank you,
for
everyone.
inviting me. Thank you. Bye, everybody.
Bye.